Yes, ma'am. We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Tnfog Marathon Cme. So it's my privilege to introduce the MOC of today's webinar, Dr. Radhika Gauri ma'am. Ma'am is specialist consultant in OBG and clinical lead at ESIC Hospital. I welcome you, ma'am, and I hand over the session to you.
Thank you for the kind words, Sahiti. Good evening, respected faculty and delegates. This is a wonderful program, Tnfog Marathon Cme, and I welcome Dr. Sampath ma'am, who will give a brief introduction.
Yes, Radhika, thank you. Good evening to all. Welcome, Dr. Sarada madam and Nagarjuna sir. This is the Marathon Cme, which is conducted for the most interesting program of Tnfog. It will be conducted on every second Friday. There will be two sessions. One session is for Yuva, that they will be giving the talk for 15 minutes. And the best Yuva will be awarded at the end of that year, that is in the Tnfog annual conference. The judge will be the same judge for 12 months. And the second session being the panel discussion. Today we have anemia in pregnancy, which is the most common cause in pregnancy, whether it is rural or urban. So this is the way we are starting this anemia in pregnancy as our first program after our new president taking over, Dr. Amala Devi, as the Tnfog president. Dr. Amala madam, welcome at us. Then we will go for the Tamil Taiwan.
Good evening to everybody, dear friends, junior and senior friends. This is the first Marathon Cme after me taking over as Tnfog president. Thank you all for the opportunity. My special thanks to Dr. Sampath, and thank you all the logicians of Tamil Nadu for making the Mugil Conference, 4th Annual Conference, Tnfog, a memorable one at Kodaikanal. As I had no chance to convey my thanks during this Marathon Cme, I am conveying my thanks to everybody of Tamil Nadu who has participated in that. My sincere thanks and salutes to Dr. Sarada Jain, who had accepted to be the chief guest of today's Marathon Cme, and Dr. Nagarjuna, who is a guest of honor. And there are this Marathon Yuva sessions. There are it talks about today the most commonest and very simple disease, but it affects the adolescent as well as the pregnant women to a large level because of the diet and everything. And this is maternal mortality also sometimes occur to the severe anemia. So the first Yuva session topic is physiology of anemia and pregnancy. The judges are Dr. Madhubala and Shantirani, who is the treasurer of Tnfog. And as Dr. Sampath said, they will be conducting this marathon, be the judges for this marathon throughout the year. And two other topics are there: investigation types of anemia, and one panel discussion is to be conducted. The moderator will be Dr. Ramani Devi, and the expert will be Dr. Revati Janakiram. Both of them were the presidents of Tnfog, the previous former presidents. And the panelists are Dr. Dasa Bharati, and then Vijitra, Dr. Sweta, Dr. Vidya Lakshmi, and Dr. Preeta, Dr. Kanmani. And Radhika Gauri is doing the MOC, and she's one of the backbone of this marathon. Like every time she's very genuinely, she does it. And I welcome every one of you who had participated in this Marathon Cme of Tnfog. Thank you.
Thank you, madam. Thank you. Dr. Sagiti, we will go with the lamp lighting and Tamil Taiwan. Yes, you start.
அத்திலக வாசனை போல் அனைத்துலகும்
Lamp lighting.
Thank you, Sakiti. Can we have the CV of Dr. Sarada, madam?
Yeah, ma'am. Yes.
Dr. Sarada, madam, is the passionate academician and a teacher, and she is the founder and the Secretary General of Delhi Gynecologist Forum. I have attended 2 of her forum also, which mainly, as she told, dealing with the basic things in obstetrics and gynecology. She is the founder and chairman of North India Gynecology Forum and privileged to be the member of Ethical Committee of NMC for 7 years. Madam, welcome to our Marathon CME and your wishes and blessings for this CME. Yes, Madam. Sharda, Madam.
Thankful to be part of this marathon CME, which is done for the whole of the state. And I was fascinated by the divine song which you played in the beginning. It was really great. This particular topic of anemia is very, very dear to me. I find, I call this anemia as a disease of century. Prior to that also, if there was anemia was there, I do not know about it. But I joined medical college in 1964. And the very first year, we got hemoglobin tested right in the physiology lab. And we found that 90% of the doctors were anemic. We went and tested the nurses. Again, 90% of the doctors were anemic with a cutoff taken as 12 gram percent. Survey, which is latest 6 IBR.
Volume.
Hello.
Ma'am, the voice is not audible.
I think all of you
Hello.
know about 2 things which are
Sarada, ma'am.
Ma'am. Yes, ma'am. Not audible. I'm sorry, ma'am, you're not audible.
Sarada, madam, you are unmuted, I think, not audible. Please unmute, madam.
I've unmuted.
Volume, slightly increase the volume, ma'am. Please.
Hello.
Ma'am has got disconnected, ma'am.
Madam got disconnected. Okay. Nagaraj sir, are you there? No?
Yes, ma'am, sir is there.
I think when Sarada madam joins, we will have her continuity. Now we have our Dr. Nagaraj sir from Karnataka. He was the past president of Kasoga and patron of Kasoga and EC member of Kasoga and founder president of Shimoga OBGN Society, organized Kasoga State Conference in 2005 and 2017, and former president of IMA Shimoga and charter member of Maland Institute of Oncology, and many more to his credit, vice president of Doctors Cooperative Society in Shimoga. His area of interest is high-risk pregnancy and adolescent issues. Welcome, sir, Dr. Nagaraj, sir.
Please, should be unmuted.
Sir, we are not able to hear you, sir.
Yes.
No, sir. Nagaraj sir, we are not able to hear you. You are on. Yes. Now you tell, sir. Yes, sir.
Good evening to all. Thank you very much for the opportunity to be associated with you all, the academic luminaries. Chief guest of the evening, Dr. Sarada Devi, Excellence Policy, and the architects of this webinar, Dr.
Amala Madam, sir. President.
Shant Kumari, Vice President Foxy, and Secretary of TNFOG, Shanti Rani, Treasurer TNFOG, on all the faculty of this webinar. As Madam was telling, the anemia is a common problem in India, especially so in all the pregnant ladies. And I feel that majority of our women are anemic. We have to focus during adolescent period and teenagers and prenatal, antenatal, and postnatal also. There is a burning issue, but we are yet to achieve anemia mukt Bharat. We have to strive hard to see that all pregnant ladies are not suffering from anemia. With these few words, I would like to thank all of you for the great opportunity, and I wish this webinar good success. Thank you very much.
Thank you, sir. Thank you so much for your presence, sir. Thank you. Sarada Madam has joined. Nagaraj sir conducted the conference when in Bijapur, I think. We met. Yes, it was a wonderful conference, sir. Okay, sir. Thank you so much, sir. If time permits, be here for the full program. We will start with the scientific session. Sakiti, Sarada Madam has joined.
No, ma'am, not yet.
Yes, Radhika, introduce the chairpersons.
Yes, ma'am. So I welcome Dr. Madhubala, ma'am, who is the president of Tnfog OG Society, and she's a gold medalist in Dippenby in 2000. And she's an alumni of Stanley Medical College and Sri Ramachandra Medical University. She's a senior consultant of Lakshmi Madhavan Hospital, Vanarapeta in Tirunelveli, and she practices obstetrics, infertility, and gynecology with equal passion. She is very famous in Tirunelveli. Welcome, madam. And I welcome another judge, Dr. Shanti Rani, ma'am, who is the treasurer of TNFOG, senior consultant in Muthu Surgical Hospital, Theni, former professor in HOD Government Theni Medical College, and former president Theni OG Society, secretary of Theni OG Society for the last 6 years from 2012 to 2018. She's the coordinator of Medical Disorders and Pregnancy Committee in FOGSI, chairperson of Best Committee Award, and won the Best Committee Award in Medical Disorders in Pregnancy. And her areas of interest of emergency obstetrics. Welcome, Shanti Rani, ma'am.
Thank you.
Thank you, ma'am. Welcome, ma'am.
Thank you, ma'am. Thank you, Radhika.
Thank you, ma'am. Ma'am, could you please invite Dr. Surya Prakash Murthy, who is our first presenter. Her CV is there. Madhubala, ma'am. Dr. Surya?
Surya is there.
Yes, ma'am. Good evening, ma'am.
Yeah. I invite Dr. Surya Prakash Murthy for a talk on physiology of anemia in pregnancy. She is a gold medalist in MBBS university rank holder in microbiology, and she is also a member of Royal College of Obstetricians in London. And she has been certified in deep endometrial laparoscopy gynecology, and she had her ART course from one state academy by Dr. Pandit Jalwar, and got Best Paper Award in ACOG Agra. Over to you for your talk, Dr. Surya.
Yes, ma'am. Ma'am, let me just share my screen. Is the screen visible, ma'am?
Yes, yes.
Shall I start now, ma'am?
Yes.
Yes,
A very
Ma,
You
you
can
start.
start.
Shobhia, you can start.
You can
Yes,
start.
ma'am.
Got it.
A very good evening to everyone. Thank you, ma'am, for giving me this wonderful opportunity. Indeed, being anemia is very prevalent, and even though we have lot of changes and lot of interventions, still we get to see lot of pregnant women being anemic, and we can able to see lot of catastrophic complications being caused by enigmatic condition, which is very wide known, being acknowledged, and being pregnancy itself is a physiological adaptation. Hematological system is not an exception. It undergoes lot of physiological changes. So it's a high time everybody must acknowledge and intervene and to prevent the complications being caused by this single particular disease. So as WHO definition, less than 11 gram being it's widely classified. And we do have a lot of different categories like first trimester, second trimester, and third trimester. This is according to WHO and ACOG classification and given in Williams' book also. So the reference range for hemoglobin and hematocrit in pregnancy, the normal being ranges from 12 to 60 and the hematocrit ranges from 36 to 46 percentage. In first trimester and second trimester, we could see there is a drastic fall in the hematocrit, which is widely normal, but the hemodilution is totally okay during the initial phases of pregnancy. It supports the mother and nourishes the baby and maintains the well-being. Only when the grading of hemoglobin it falls less than 7 that becomes severe and that has its own complication and effects on both the mother and the baby as well. If the anemia is mild, which ranges from even though the mild anemia category is from 10 to 11, it has its own symptom on the mother, starting from fatigue or lightheadedness, mild exertional dyspnea to happen. If the woman has moderate severe anemia or it has its
Yeah. Okay.
various systemic manifestations like palpitations or tachycardia or poor concentration that has its own effect on the fetus itself. So the daily impact of the women gets affected. Not only the daily balance, it also affects both the performing cognitive and also the mental condition of the women. So there is a paper which is released in the PubMed that has its that clearly states the maternal morbidity and the mortality linked to anemia. So if anemia happens during the course of pregnancy, there is a chance of infection, postpartum hemorrhage, and the need for transfusion. And also, it indicates the severe anemia or moderate anemia has its own effect on like preterm labor, preeclampsia, and abruption that has also an important cause in going for emergency C-section as well. Even after the baby is delivered, most of the mother with anemia couldn't able to perform very well and they might have experienced postpartum depression or blues. So it's not only the condition that has to be taken for throughout the pregnancy and also in the postpartum period as well. So it has impact on the quality of life, mental health, and the functioning. So a paper published in the Cochrane data that has clearly mentioned like anemia associated with a poor quality of life, depression, fatigue, and also it plays an important role in impaired cognition. So why everyone talking about like maintaining a good quality of life? Because pregnancy itself has its own like mood disorders and well-being would be affected. If the mother feels low, obviously the entire family would be agitated like she's not doing well. So it impacts the daily work-life balance of the mother and also her household things and stronger mind and stronger bond creates and overall it impacts the quality of the life. So, what are the perinatal outcomes? Why anemia matters for the baby? It has its own perinatal risk. Severe anemia is lead to stillbirth and early neonatal mortality. We do have lot of publications linked to the perinatal mortality and the morbidity for this. That is the wide known as it's given in the MSD manual, which is the recent publication, and also in Cochrane database that clearly mention anemia has its significant link to the neonatal mortality and the morbidity as well. So, what happens during the initial phases of pregnancy, which is the physiological anemia? The major hematological adaptations include it starts from the moment the women become pregnant, the plasma volume starts rising. It reaches peak between early second trimester and the late third trimester. So the plasma volume and the RBC changes widely happen. The plasma volume rises like around 40 to 50%. And the expansion of the erythrocytes, which is the RBC cell mass expansion, happens to 15 to 20%. The increased cell mass expansion, like increased erythropoiesis, that's because of to meet the increased oxygen demand. So the basic physiological adaptation happens is rise in the plasma volume and the fall of hematocrit and the RBC mass expansion, which is the increased erythropoiesis that happens to meet the increased iron requirement that is going to happen throughout the pregnancy. So the plasma volume expansion, the timing, if you see, look into this chart. So whenever the woman becomes pregnant, the early second trimester, the peak happens at the 28 to 40 weeks. So how much the expansion happens? It's roughly around from late pregnancy, 1,700 to around 2 liters, the expansion happens. And also there is a dilutional fall in hemoglobin. So it is like whenever the any change that happens during the early trimester that is seen throughout mid and late pregnancy, and the entire physiological changes resume to her normal level, like pre-pregnant level, only in the postpartum phase. Like I think there is an interruption, ma'am. We'll reshare it again.
Thank you.
Yes, ma'am. Sorry for that call in between, ma'am. So what is the mechanism driving the plasma volume expansion? So the hormonal drivers being estrogen and progesterone and the renin-angiotensin activation and sodium and water retention. So that is the basic physiological mechanism between the plasma volume expansion and also certain vasodilator mechanisms taking place, which is nitric oxide release and prostaglandins and relaxin. These are all vasodilators that leads to the expansion of the blood vessels, ultimately rise in the third space volume. So automatically the plasma volume expands to 50% during the start of the second trimester until the last of the third trimester. And another physiological mechanism being the red cell mass expansion. That happens to 25% in a singleton pregnancy. So let's just imagine what happens in a twin pregnancy and triplet as well. That's why in twin pregnancy, it's the anemia becoming more evident in the early trimester onwards. So all these regulatory mechanism, it's the physiological component, which is the erythropoietin that especially that takes place in the late second trimester. So as we discussed, so RBC expansion, plasma volume increase, and increased requirement of erythrocytes, which is the erythropoiesis. This erythropoietin stimulates the erythroid hypoplasia. So these are all the basic physiological key factor in the hematological reasons behind causing dilutional anemia. So how the hemodilution in the causes anemia without the marrow failure? I think it's a lot of disturbance. Yes. The increase in plasma volume dilutes the circulating RBCs, lowering the hemoglobin concentration per deciliter. And the total RBC mass increases like 15 to 25% in singleton pregnancy, but plasma volume increases to 40 to 50%. This hemodilution, which is more pronounced in the second trimester, at the same time, the marrow failure does not happen because it is a physiological adaptation. Even though the fall is like 1 to 2 grams per deciliter throughout the pregnancy, the plasma volume expansion dilution happens. Even though the hemoglobin lowers, hematocrit lowers, it is like a hemoglobin hematocrit rescue. So the erythropoietin and the erythropoiesis, which is compensate without going in for marrow failure. Only when the need is much more, or if the woman is having a low reserve, then the iron deficiency, like the shift from the physiological to pathological, takes place. So the oxygen delivery in physiological anemia, why it usually surfaces? Because the RBC mass expands, the cardiac output increases, automatically the placental perfusion also increases, and the blood viscosity, it's getting reduced. So the hematocrit and the hemoglobin is lower, which is quite often seen in early second trimester and the third trimester as well. So these changes happen and the tissue oxygenation remains adequate. All the symptoms are minimal or even absent. If the fall is more, or if the woman is not able to meet the requirements, then the shift from physiological to more severe anemia usually happens by late of second trimester. So what happens when that shift happens? Like many women start pregnancy with marginal iron stores because of any diet or a short interpregnancy interval. When there is inadequacy of good supplement intake, normally the pregnancy demands around 500 to 800 milligram of additional iron. If the woman is not having a healthy supplements or any sort of iron tablets, or she's not taking any nutritional benefits, then obviously the pathological anemia takes place. The fall is greater than expected in the second trimester, and the RBC mass is either normal or decreased. The iron stores which is there, that gets depleted, and the marrow response to that erythropoiesis, it's faster. So the women start experiencing fatigue, palpitation, and breathlessness quite earlier when compared to the other normal pregnant women. So this hepcidin and ferroportin axis, this is the core physiology behind the physiological anemia. Hepcidin is something that's a protein which is released by the liver, and that is a transporter, like that transports the iron molecule. So whenever hepcidin is there, so it binds to the ferroportin, which is a transporter of the iron. So when hepcidin is increased, obviously ferroportin will be lower because that would be bind and the iron availability will be reduced. So then there is a risk of iron deficiency. So what happens in pregnancy is, since this ferroportin is a transporter, normal physiological state of pregnancy is there is a low hepcidin. So whenever the hepcidin is low, the ferroportin shoots up. The iron availability increases. So whenever iron availability increases, that would be sufficient for both mother and the fetus. That is the normal physiology. So this. I'm not saying this is the core reason for getting physiological anemia, and this is one of the causes for getting physiological adaptation in pregnant women. So in total, before conception, many women enter pregnancy with low or marginal iron stores. If her sources are sufficient, she could able to manage it. Or else any poor absorption or inadequate dietary intake, obviously she might feel some of the symptoms during the course of pregnancy. And the regulatory response is hepcidin and ferroportin transport mechanism. So if inadequate supply of other B12 or folate happens, probably because of poor intake or malabsorption or increased loss, so then obviously she might need to face some of the consequences because of the iron deficiency. So what are the key difference between the physiological and the pathological one? Physiological is usually normal between second and third trimester, like 1 to 2 grams per deciliter fall. And the pathological is much lower than the expected for the gestations. Probably she can go for like 7 to 8 grams per deciliter at any point of time. Physiological is asymptomatic or minimal, and probably she could able to feel some fatigue, dyspnea, or palpitations or lightheadedness during at any point of time if she gets iron deficiency anemia. The main difference, key difference we could able to remember is like the ferritin usually is normal in physiological anemia. And what happens in pathological, the ferritin becomes low, which is less than 15 nanogram per ml, and also low serum iron, but the total iron binding capacity is quite increased. So, and also if we could see in megaloblastic anemia, all the changes would be there, but there would be ineffective or inadequate erythropoiesis, and also macrocytosis would be there in megaloblastic anemia. So that is the key pathological finding we could able to identify. So finally, this is the comparative table to differentiate between physiologic one and the iron deficiency anemia and the folate and anemia of chronic diseases. So this we could remember in all these physiological studies. So what are the other reasons apart from physiological? The pathology include any hemoglobinopathies or chronic inflammation or acute hemorrhage or GI bleeding or any parasitic infection that might add on to the hemoglobin loss as well. So the key take-home message is anemia is physiological, but the iron deficiency is the main pathological driver, and the key mechanisms being plasma volume expanded and RBC mass expansion, and the hepcidin ferroportin axis becomes the one of the main reasons for the shift. The physiological dilution happens, which is quite normal, and that is the one of the key adaptation that happens in the pregnancy as well. If the woman is able to manage it overall, she could handle it very well throughout the pregnancy. So these are all the references I could able to collect it. And thank you so much. Thank you, ma'am, for giving me this wonderful opportunity. Thank you, ma'am.
Thank you, Dr. Surya. That was an excellent presentation.
Thank you, ma'am.
Madam audible? Adubala, madam. Surya, am I audible?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah, your topic is excellent. And we are talking much about dilutional anemia in pregnancy. That is the main physiological adaptation, what we are concerned about.
Yes,
And
ma'am.
what is the advantage of physiological anemia? Why body has to adapt to that?
Ma'am, it has to support both the mother and the fetus.
Yeah,
So
dilutional anemia. Yeah, you proceed.
So whenever there is like increased dilution or increased plasma volume, then only it has to support another circulation as well.
Yeah, to increase the uteroplacental blood flow. That's
Blood
one
flow.
thing. Another thing is why body increase the volume so much. Pregnancy adaptation is mainly for to compensate the blood loss.
Blood loss.
During delivery, the body is expecting to lose blood at the time of delivery. So the physiological mechanism adaptation is mainly to increase the blood flow. Uteroplacental blood flow, the blood is becoming so thin, dilution. And also to cope up the blood loss during delivery. So what is the disadvantage of this physiological adaptation? Body wants to do this. What is the complication when the blood is becoming hypercoagulable and hemodilution occurs?
Whenever there is multiple pregnancy, probably the mother can suffer much more than with singleton.
What's the thing is that physiological anemia, the erythropoietin level usually increases, and there is an increased demand of RBC mass. So already the blood RBC mass is not proportionately increased, and that is also increased demand by the baby. So this physiological anemia, the patient not taking iron, they will immediately turn over to pathological anemia. That's one of the disadvantage. And also because of this hypercoagulable status, patient may go for
anytime thromboembolic complications can happen.
Increase in symptoms. So the physiological adaptation is for benefit, and we should be careful about the physiological adaptation also. I think you talk about hepcidin and all, and hepcidin is not related to a lower hepcidin that increases the absorption of iron.
Absorption of iron. Iron availability increases.
Yeah, that's the only point regarding the hepcidin. I think all the other things, laboratory and other thing, I think it will be dealt by the next person. Any questions from madam? You want to talk about some Bohr effect? What is the adaptation in the system? Bohr effect, how it changes oxygen dissemination to the baby. There is always a shift to right. The fetal adult hemoglobin has a capacity to lose its oxygen easily to the fetal hemoglobin. So the oxygen affinity is reduced. Bohr curve is towards the right side. That are all the physiological adaptation. Usually, as an undergraduate should know, usually we used to teach like that. Thank you. Thank you for that. Thank you.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, ma'am. The next presenter, Sahiti. So next, I invite Dr. Shantirani ma'am to introduce Dr. Monisha, please.
I invite Dr. Monisha. She's working. She's currently working as assistant professor at Sri Muthukumaran Medical College and Research Institute, and she did her MBBS in Government Thuthukudi Medical College and MS in Government RSRM Hospital. And she's also a DNB holder. And her area of interest is high-risk obstetrics and minimally invasive gynec surgeries and infertility.
Thank you.
Over to you, Manisha, regarding the investigations and the types of anemia.
Thank you, ma'am. Is my screen visible, ma'am?
No, not yet, ma'am.
Not yet. Not visible.
Now is it visible, ma'am?
Yes, visible.
Yeah, I can see.
Good evening, everyone. Today we are going to see about the classification and investigations of anemia. from morphology to molecular diagnosis. So, as a definition, according to WHO, it is a condition where the number of RBCs or the hemoglobin concentration is lower than the normal, reducing the oxygen carrying capacity of the blood. So, why is it important? Because this anemia accounts for 20% of maternal deaths in India, and the iron deficiency anemia itself is constitutes 60 to 70% of anemia in India, and the overall anemia percentage prevalent in pregnant women is around 50% in India and in Tamil Nadu also. So trimester wise, the WHO classification has been done. First trimester when it is less than 11 gram per deciliter, second trimester when it is less than 10.5, and third trimester less than 11 grams. So the classification, it can be divided as clinical classification, etiological classification, and the morphological classification. According to the WHO, they have divided a trimester wise as mild, moderate, and severe. And severe, it is less than 7 in all trimester. And according to ICMR, the classification is mild, moderate, severe, and very severe. Mild is 10 to 10.9, moderate is 7 to 9.9, and severe is 4 to 6.9, and very severe is less than 4. So the etiological classification, first is the blood loss. Blood loss can be acute due to trauma or the surgical bleeding, and chronic due to gastrointestinal causes or the gynecological causes, and impaired RBC production. That is underproduction of the RBCs because of defective DNA synthesis. It's mainly due to the megaloblastic anemia because of vitamin B12 or folic acid deficiency, and defective hemoglobin synthesis in case of iron deficiency anemia or the anemia of chronic diseases, and bone marrow stem cell failure, aplastic anemia, or other myelodysplastic syndromes. And coming to the hemolytic anemia, it can be divided as inherited and acquired. Inherited or the hemoglobinopathies, the enzyme deficiencies, G6PD deficiency and pyruvate kinase deficiency. The membrane disorders like hereditary spherocytosis, and in extracorporeal corpuscular, it is familial HUS, and acquired paroxysmal nocturnal hemoglobinuria, and in extracorporeal, again, it's microangiopathic, TTP, HUS, HELP, all comes under this, and drugs, toxic agents, infectious causes, autoimmune hemolytic anemia, all are acquired. Coming to the morphological classification, it can be divided as microcytic, hypochromic, normocytic, normochromic, and macrocytic, normochromic. Microcytic hypochromic, mainly it has 4 classifications like iron deficiency anemia, sideroblastic anemia, anemia of chronic diseases, and thalassemia. Normocytic can be again divided as because of hemolytic anemia or due to the underproduction of the RBCs like aplastic anemia and myelodysplastic syndromes. And macrocytic anemia, it's mainly due to vitamin B12 deficiency, folate deficiency, and thiamine deficiency. So coming to the investigations, just with the low HB report, what else matters? Think beyond the box. So the etiology matters. How do you assess the patient? First comes the clinical assessment. By the history itself, as you all know, the dietary history, pica, and menstrual history, obstetric history, GI, or any other sources of bleeding, and drugs and toxins, family history, symptoms like fatigue, dyspnea, palpitations. These are all important in history taking. And in examination, PELA will be noted and addressed. Koilonychia, anglostomatitis, glossitis, lymphadenopathy, hepatosplenomegaly, edema. And the red flags, when the hemoglobin is less than 7 gram per deciliter, hemodynamic instability, active bleeding, and pregnancy with symptoms and hemorrhagic fever. So the diagnostic algorithm. So once you see the report as low HB, what else do you order? What else matters is the peripheral smear, reticulocyte count, and in the CBC, not only the HB, but you also look at the MCV. Based on that, you divide it as microcytic, normocytic, and macrocytic. So the 7 tests that decides the diagnostic skeleton. First is the CBC, next is the peripheral smear, next is the retic count, and ferritin for the iron stores, B12 or the folate, and hemolysis. For that you have to order LDH, bilirubin, and haptoglobin, and RFT, LFT, TSH for the systemic causes. So other evaluations, when clinically indicated, you have to go for gastrointestinal evaluation, coagulation studies, HB analysis, and bone marrow biopsy. So we will discuss all these in detail. Coming to the microcytic anemia, when the MCV is less than 80 femtoliters, can be due to iron deficiency anemia, anemia of chronic diseases, sideroblastic anemia or lead toxicity, and the thalassemia trait. So in iron deficiency anemia, the characteristic feature is a reduction in the ferritin. The likely causes are inadequate intake or the increased demand of chronic blood loss or malabsorption. When the ferritin levels are normal or high, it can be due to anemia of chronic diseases or sideroblastic anemia. The additional tests required may be HPLC and lead levels and bone marrow biopsy. So in iron deficiency anemia, what is the pathogenesis? So first occurs the negative iron balance. The iron stores are getting reduced. Erythron iron is nothing but the circulating iron and the RBCs in the bone marrow cells. So that will be normal and the iron stores will be in negative balance. And next comes the iron deficient erythropoiesis. Now the circulating iron is also reducing and the stores are also getting completed. And the iron deficiency anemia, iron stores will be depleted and the erythron iron is also much reduced. So when you diagnose the patient as iron deficiency anemia, it is already late. She has lost all the stores and also the circulating iron in her body. Coming to the marrow iron stores, it will be 1 to 3 plus and 0 to 1 plus, and there will be nil iron stores in iron deficient erythropoiesis and iron deficiency anemia. The main thing here to note is the serum ferritin levels. The normal is 50 to 200 microgram per liters. In negative iron balance, it will be less than 20. So if you pick up at this level, you can detect the iron deficiency anemia earlier. So when it is less than 15, it can be due to deficient erythropoiesis or the deficient anemia. The next thing you see is that total iron binding capacity, it will be increased in the iron deficiency anemia. It is more than 360, more than 380, and more than 400 in iron deficiency anemia. And also you have to note the transferrin saturation. It is less than 50 in iron deficient erythropoiesis and less than 30 in iron deficiency anemia. The RBC morphology will be microcytic hypochromic only when the anemia is diagnosed. So ferritin is the earliest marker to fall and is the first line test to detect. But it is an acute phase reactant, so it might be falsely elevated in infection or inflammation. So it is the anemia is as per se, when it is diagnosed in the late stage. A normal HB does not exclude a depleted iron stores. So these are the normal ranges of the CBC report. Next, coming to the thalassemia, it is again the microcytic hypochromic anemia. So here the 2 alpha and 2 beta globin chains are there. As you see here, the molecular structure of hemoglobin, it is composed of heme and globin. So there is a defect now in the globin chains. When the beta chains are defective or reduced or absent, the beta thalassemia will occur. So how it is inherited? When a mother is a trait, there is a 50% chance of the children being a trait. When the father is also a trait, then there is 50% of a trait and 25% of being a thalassemia major. So how will you diagnose? So often it is asymptomatic and family history matters. And also the Menzel's index is very important. You calculate it by MCV by RBC. It is less than 13 in thalassemia, whereas it is more than 13 in iron deficiency anemia. And microcytosis with the normal or mildly reduced HB will be noted. Target cells and basophilic stippling will be there. Here you see the peripheral smear of the thalassemia patient. Here it is basophilic stippling, target cells will be noted, teardrop cells will be noted. This is a report of the HPLC. So as you see here, in normal patients, HbA adult hemoglobin will be in 96 to 98% level. But in beta thalassemia trait, the HbF, this is the fetal hemoglobin, and HbA2 level will be raised. And in beta thalassemia major, the fetal hemoglobin and HbA2 level will be even more increased and HbA level will be decreased. Alpha thalassemia trait can be diagnosed only by genetic testing. This HPLC doesn't matter much. So coming to the sideroblastic anemia, it is an iron-containing erythroid precursors. There is a defect in the incorporation of the iron into the heme. So the iron will get deposited in the cells and it will present as a granules. So in bone marrow biopsy, if you see by the Prussian blue stain, there will be a characteristic ringed sideroblast will be noted. And peripheral smear will be mostly microcytic, but it can be dimorphic. Here you see the bone marrow biopsy with the Prussian blue stain showing the ringed sideroblast. So the comparison of the microcytic hypochromic anemia, I just want to skip this, and normocytic anemia, it might be due to hemolysis or due to underproduction. Diagnosis of hemolytic anemia by the retic count, it will be elevated because of the rapid hemolysis. The marrow wants to compensate it, and indirect bilirubin will be raised, LDH will be raised, haptoglobin will be reduced, peripheral smear shows spherocytes, schistocytes, sickle cells. DAT will be positive in autoimmune hemolysis. Here you see the schistocytes, which are helmet-shaped cells, which is seen in microangiopathic hemolytic anemia, and you see the spherocytes in the spherocytosis, and sickle red cells in sickle cell disease. And sickle cell anemia, in thalassemia, the main difference is there is reduced or absent beta chains. But here, the beta chains undergo mutation where the glutamate is replaced by the valine. So there is the sickling of the RBCs, which can cause tissue hypoxia, occlusion, and this organ damage. Chronic hemolytic anemia may be present. How will you diagnose this? Family history matters. Newborn screening can be done. There will be decrease in the hemoglobin and the hematocrit. HP electrophoresis can be done to identify the HbS. Coming to the microangiopathic hemolytic anemia, which again matters in the pregnancy, it is of HELP syndrome, TTP, traumatic thrombocytopenic purpura, or the HUS. HELP syndrome, the characteristic feature is a preeclampsia, which is diagnosed clinically. So in TTP, the differentiating feature is thrombocytopenia will be present and neurological symptom will be seen. And in HUS, the associated renal failure will be seen. So the key laboratory tests in HELP syndrome, mainly the BP measurement and the abnormal liver panels and the coagulation profile. In traumatic thrombocytopenic purpura, you go for undetectable or decreased Adams 13 levels. And in HUS, the complement levels, or if it is due to shigalic toxins, the positive Shiga toxins will be noted, or abnormal complements will be noted. Aplastic anemia, this is due to pancytopenia. It can be idiopathic or marrow infiltration. CBC shows pancytopenia. Bone marrow biopsy shows hypocellular marrow with fatty replacement. The other causes are myelodysplastic syndrome, which is diagnosed by cytogenetics or molecular studies, PNH by flow cytometry, and viral infections. If it is Fanconi's anemia, you do a molecular genetic testing to diagnose. So the bone marrow examination when to consider the unexplained anemia, pancytopenia. It can be done in pregnancy. It does not need to be deferred until postpartum. Rarely, Persian blue stain can be used to diagnose the ring sideroblasts. When there is resistance to treatment or refractory cases, you can go for bone marrow biopsy. Coming to the macrocytic anemia, it is due to B12 deficiency or the folate deficiency because of the malabsorption, poor dietary intake, or the increased demands. Defective DNA synthesis is there here. Nuclear cytoplasmic asynchrony will be there, and so the megaloblasts will be seen. The characteristic features is the peripheral smear, megaloblasts, and the macrocytes and hypersegmented neutrophils will be seen. So I want to make a note of this point of care hemoglobinometers. There is HemoQ, which is available, which you can do it in a low resource settings, or when you do in a community screening. Just by a finger prick, you can make out the hemoglobin levels. And this is an easy check non-invasive screening device by the optical or spectrophotometric method. Without even a prick, you just estimate the hemoglobin estimation. Of course, they have their own errors because it's not a venous sample. The goal is not just to label the anemia, it is to identify the mechanism and treat the cause. So the take-home message is iron deficiency anemia is the commonest cause. You have to order a ferritin level for that. First, you see the hemoglobin, and then you look for the MCV levels and divide it into microcytic, macrocytic, or the normocytic, and you look for the iron studies. MCV is the fastest sorting tool. And reticulocyte count separates the production failure from the hemolysis or blood loss. Anemia with thrombocytopenia, you look for the LFT levels, look for the BP levels, BP recordings, and exclude HELP and TTP. Not every microcytic anemia is IDA. So you have to go for the ferritin studies. A structured 4-test score panel, CBC, indices, smear, reticulocyte count, ferritin solves most of the cases. Thank you, ma'am.
Madhu madam, is that a very good presentation, Monisha?
Thank you. Thank you.
Actually, I was very happy about the slide about your clinical features, because nowadays nobody is asking, seeing the patient to put out the tongue or see the conjunctiva. That is way we have been taught, but nowadays the clinical judgment is very much lost. And I'm very happy that you put the first slide as clinical manifestation, clinical features.
Thank you, ma'am.
Happy. And regarding this serum ferritin estimation, all the other things you clubbed everything is in a microcytic, normocytic. So the lab features along with that are clubbed in a beautiful way. I really appreciate that. And regarding the serum ferritin, what is the guideline says whether it should be done as a first line of investigation or in a low resource setup? What are you doing in your Muthukumaran hospital?
Actually, ma'am, we go for CBC. We diagnose just by CBC and peripheral smear, ma'am.
Yeah.
But if at all, again, the CBC will report as microcytic hypochromic anemia. But if at all, only in refractory cases not responding to the IV iron or something, we go for
When
the
we
iron.
suspect hemoglobinopathies in your place or with the history or with the patients not responding, we are going for a serum ferritin because the WHO is not saying that you should screen all patients with serum ferritin. That should not be the idea. A simple complete blood count and a peripheral smear. Hemoglobin hematocrit will do. Microcytic hypochromic anemia is the commonest and unless otherwise proved it is an iron deficiency anemia. I think Madhubala madam want to add something.
Madam, sometimes what happens is we have to have some discretion for the patients, I think, because when vegetarians are there, when we have the history taking properly, when the vegetarians are there, it's better to go for ferritin levels even in the first trimester so that we can treat them accordingly. And sometimes, as rightly said, when the hemoglobin is not rising up with our normal iron medications, in our we see lots of hemoglobinopathies, especially beta thalassemia traits. So in that case, we'll be a little embarrassed when we diagnose it a little later because we've been giving her loads and loads of iron and serum ferritin will shoot up and then only we will be having in our mind, why don't we? Yeah. So that is better. So I always think it is better we do the entire anemia profile even in the first trimester after a shared decision making with the patient. After taking a proper history taken.
That was put in the last slide by Monisha. That is all should be combined and but as
But
for
we have to discuss with the patient. The consent of the patient is also essential. If they are constantly anemic, we can tell them about because the cost is also a matter for patient.
So individualized. Okay. Anything, Madam Sampath Madam want to add? Madam is there. Ramani Madam is there. Regarding the talk.
Dr. Shanti and Dr. Madhubala, the questions will be asked only by judge, not others.
Okay, madam.
You have to give the marks.
I think then it's over.
That's all. Only you both will ask.
Yeah. Then it's over because we are the person judging and putting the mark and for the selection. Thank you.
Formula we have to put the mark. That's all. If it is
Yes.
over, we will go with the panel.
Madam and myself talked about how to channelize the score
You can
sheet.
discuss later also.
Already we discussed, madam. Thank you. Thanks a lot.
Thank you, Dr. Madhubala and Dr. Shanti Rani.
Thank you, madam.
For
Thank
12
you.
months, you will be the judge.
Congratulations for both presenters, madam. They have done a good job. Done a good job.
Surya and Monisha, wonderful presentation.
Yeah.
Wonderful presentation. I wish all the PGs have seen this such a beautiful presentation, madam.
Yeah.
No PG has joined. That is the reason yesterday we made in all the groups. We will try to improve.
Yes.
We'll do it in future, madam. This is of short time notice. We'll do it in future.
Sure, ma'am.
Sure. Thank you.
Now Radhika will go with the panel discussion.
Thank you, madam.
Radhika, we'll start the panel.
Sorry.
நான் introduce பண்றேன். ராதிகா இருக்கியா?
இருக்கேன் மேம். மியூட் ஆயிருந்தது. நான் பேசிட்டு. Yes ma'am. So thank you Madhubala ma'am and Shanti Rani ma'am. We'll move on to the next session, which is a panel discussion on anemia and pregnancy. I request and welcome our Madam Dr. Amani Devi ma'am. She is the moderator. She is the president of TNFOG 2024.
Enough, Radhika. You move on to the expert. Revati madam will be the expert for this panel.
Yes, ma'am.
And she has been the past vice president and the TNFOG president of TNFOG president, and she has received so many awards and Lifetime Achievement Award, and she's won Master Trainer for PPIUCD.
Revati madam,
and contributed so many things to Foxy and especially to TNFOG. So apart from this, we have a young dynamic panelist, Dr. Dasa Bharati Yuvashri, who is a private practitioner from Palani. And she has obtained her gold medal in psychiatry in MBBS. But still, I think she has come back to OG. And best of poster presentation and senior resident in Jipmar SRM Medical College, and assistant professor in Velamal Medical College. Her field of interest is high-risk obstetrics and preventive oncology. Next panelist is Dr. Vijitra, who is a consultant at Vijay Hospital, Karur, and area of interest is fetal medicine and infertility. Next is Dr. Sweta, consultant obstetrician and gynecologist from Aravind IVF Center, Anbu Nursing Home, Karur, and she's a member of IMA Karur, Foxy Karur. Areas of interest are reproductive medicine, ART, high-risk obstetrics, and endogynecology. Then the fourth person is Dr. Vidya Lakshmi from Aishwarya Fertility Private Center. That is, she has completed her MBBS from Tanjavur Medical College and MS from Tirunelveli Medical College. And she's interested, her field of interest is fertility care, reproductive medicine, assisted reproductive care, high-risk obstetrics, and gynec. And she's a professional membership from IMA member. Next. Dr. Preeta. Nothing is there, but still Dr. Kanmani. I hope all the six of them are present for this panel. I'll be making it as simple as possible. Okay, from what they have learned from the previous speakers. My screen visible?
Yes, ma'am.
Okay.
No, ma'am.
No,
ma'am.
Madam, screen visible இல்லையே.
இல்லையா அப்புறம்?
நீங்க தான் தெரியுறீங்க, screen தெரியல.
இல்லையேப்பா, நான் வந்து இருங்க. I'll just share. இப்ப தெரியும்னு நினைக்கிறேன்.
இப்ப ஸ்டார்டிங்.
எஸ்.
தெரியுது மேடம்.
ஓகே.
ஓகே.
ரேவதி மேடம் இருக்காங்களா?
ரேவதி மேடம் இல்லன்னு நினைக்கிறேன்.
சாந்தி,
ரேவதி மேடம்க்கு சொன்னீங்களா சாந்தி?
மேம் டிராவல்ல இருக்காங்களா மேம்? ஜாயின் பண்றேன்னாங்க. கொஞ்ச நேரம் ஆகும் ஜாயின் பண்றேன்னாங்க.
சம்பத், you be the expert. Okay. Okay. So anemia definition in CDC in 1990 defines hemoglobin when it is less than 11 grams percentage in the first and the third trimester, they call it as anemia, and less than 10.5% in mid trimester, we call it as anemia. But WHO states that anybody at any trimester of pregnancy, if she is less than 11 gram percentage, then she is called as an anemic woman. So now let me ask my panelists, what is the incidence of anemia? Is it more or it has been slightly lesser than what it was in yester years, or still continue to be on the higher side? Any one of you, according to the National Family Health Survey, is there any difference between the rural and the urban area?
Ma'am, despite various measures, the anemia in pregnancy is still on rise, ma'am.
Yes.
It was stated by National Family Health Survey. According to 2015, it was around 50%, ma'am, in India. But around 3 to 4% it has been increased, ma'am, so far. And it is more prevalent in rural areas, ma'am.
Yes. But there is only a meager difference between the urban and the rural areas.
Yes,
still, it continues to be roughly 50% this way or that way. The women are anemic during pregnancy. But when we take the WHO data worldwide, it is only 35%. That means India has to work hard to make our women less anemic. Why it is so important? Dr. Dasa Bharati, you tell me why anemia why everybody is focusing on anemia. What will happen to the woman when she is pregnant because of anemia? Anybody can answer.
Ma'am, Sorry for the strained voice. Anemia is a very important marker, precursor for maternal morbidity and mortality.
Yes.
It is either a direct cause or an indirect cause. Throughout
Okay.
the pregnancy and the postpartum period, the single important factor, anemia, is a reason for many other diseases that she can acquire during pregnancy, during delivery, and in the postpartum period. So it
Yes.
is important that uh,
Both it can cause maternal morbidity as well as mortality.
fetal.
So
Yes.
what will be the, if one patient dies, what will be the number of patients who are having morbidity? See, we always say mortality, 20% direct cause, 20% indirect cause. But you know, behind the screens, it is how many percent of them have a morbidity? For every one maternal death, at least 10 to 20 women suffer from morbidity. So that means morbidity is much more, and we need to cut down. Now, having conquered the maternal mortality, especially in Tamil Nadu, the next we should focus on morbidity. Okay. So the next is, what is the prevalence of anemia in pregnancy, during pregnancy? I think the overall prevalence, you have said it is 40%, and it is 3 to 4 times higher in developing countries. And you have clearly, Dr. Sweta has said it is more common in the urban, rural areas than in the urban. And even in the developed countries, 18% of the women are anemic when compared to 40% in the underdeveloped. See, in India alone, the prevalence is as high as 88%. Okay. So how was ICMR categorizing anemia? So that means I just want to know what is the grades of anemia according to ICMR.
Mild, moderate, severe, very severe, ma'am.
So why this gradation should be there? What is the clinical significance? See, suppose I see a patient who is severely anemic, but at the same time I'm seeing a patient who has got mild anemia. How does it differ in my management? Is it important or not?
Mild anemia, normally it might be due to hemodilution mainly, whereas in case of severe anemia, patient will require blood transfusion, be it at any trimester.
Yeah, so that is the significance. The clinical significance is, if it is going to be a severe anemia, irrespective of the gestational age, we need to treat the patient intensively with blood transfusion. But in patients who are having mild to moderate, if they are in the early phase, then probably iron supplementation will help. So now with this introduction, let us move on to the case scenario 1. Mrs. S, 30-year-old, gravida 6, para 5, 0, presented with the OPD for antenatal checkup at 30 weeks of gestation. She did not have any antenatal care. She complains of fatigability, irritability, weakness, and shortness of the breath. So from this history alone, what will be your probable diagnosis and how you will focus your evaluation of that particular patient? Dr. Vichitra, is she there?
Ma'am, Dr. Vijitra ma'am is in emergency, ma'am. She'll join shortly, ma'am.
Whoever is there, you can take up the question.
Ma'am, this patient is a 32-year-old and she is 5th gravida. And she had already had 5 pregnancies, and at 30 weeks, when she's complaining of fatigability, irritability, weakness, and shortness, it is more pointing towards iron deficiency anemia. And because of previous 5 deliveries, might be her stores would have been depleted.
And again, there is no antenatal for this particular pregnancy. And we do not know the history, how short it was the in-between pregnancy period. That is also important. No, sooner the pregnancy, then likely the chances for anemia is going to be more. So the clinical findings of that patient, what are the clinical findings we generally expect in this patient with severe anemia multigravida?
So on examination itself, patient will be very pale, ma'am, first of all.
Yes, yes.
Pallor will be there, and there will be shortness of breath in case she is having, if she is severely anemic.
Already I have given the complaint that she complains of shortness of breath. So what will happen to the pulse rate and the respiratory rate?
She'll be in tachycardia.
Yeah. Tachycardia, tachypnea.
Hypertachypnea.
hyperventilation may be there because of hypoxia. She will definitely have associated other deficiencies, not only for iron, but folic acid and B12, everything will be low. Glossitis, stomatitis, and then the lower extremities, she has clinically edema. So edema doesn't mean that it is only preeclampsia. It can also be because of anemia. So what is the cause for edema in anemic patient?
Failure, ma'am. Anemia with failure can present.
It may one causes, rightly you have pointed out, it can be because of failure. Common cause, apart from that.
Associated hypoproteinemia would be there.
Yes, hypoproteinemia is the most common cause in these situations. And this patient has got severe systolic murmur, that is pathognomic of anemia, severe anemia. Probably between these two previous pregnancies, she has not given a history. Probably if she is going to be a cardiac patient, then she would have been diagnosed earlier or treated. So probably cardiac cause has been ruled out. Then on obstetric examination, her fundal height is 36 weeks, more than her period of amenorrhea, and fetal heart is located at two different sites. So what is the probable diagnosis here? More than period of amenorrhea, 2 FHRC.
Multiple pregnancy.
Multiple pregnancy. So all the more, this is a case of severe anemia, probably in early failure, complicated with multiple pregnancies, multigravida with multiple pregnancies. So she falls under which category? High risk or moderate risk or low risk?
High risk, ma'am.
High risk category. So now what are you going to do? Are you going to ask for investigations? Are you going to get her admitted or treat her as OPD patient?
Get her admitted.
She needs admission. Then, okay, what are all the investigations would you like to do? So previous speaker has been beautifully telling what are all the investigations one should do when you suspect anemia. Tell one after other.
Complete blood count, ma'am, with peripheral blood smear, and followed by serum ferritin, thyroid profile, glucose challenge test, viral markers, urine routine and urine culture and sensitivity, and ultrasonogram for the fetal and the placental profile.
Okay. So in peripheral smear, is it important or not? What are all the things you will get from the peripheral smear?
In peripheral smear, we get to know about the typing of anemia. We get to know about the other cell lineages regarding the WBCs and the platelets. And also we get to know about the if there is any malarial parasites, we get to know about it also, ma'am.
See, why you omitted this B12 serum for B12 and serum folate levels? That can even be simply found out by the complete blood count.
Yes, ma'am.
What is the shape of the RBCs and what will be the volume of the RBCs?
The volume of the RBC in B12 and folate deficiency will be, the MCV will be more than 100 femtoliters, ma'am, which will be macrocytic, and associated in peripheral smear, you get hypersegmented neutrophils and with macrocytic hypochromic anemia.
But in this particular patient, do you think that macrocytic hypochromic anemia is going to be the factor or it is a combination? Combination, because multigravida with multiple pregnancy, no antenatal consumption of iron, she is likely to have suffer from both iron deficiency, B12 and folic acid. So then what is the significance of TSH in these patients? Why do you want to do TSH? And what is the relationship between TSH and the anemia?
In hypothyroidism, there is chances of macrocytic anemia, ma'am. Macrocytic anemia is with hypothyroidism.
Then?
It can cause anemia which does not respond to nutritional supplements.
If TSH is on the lower side, probably the response to your oral supplementation of iron or B12 or folic acid may not be effective. So that is why we need to do. And of course, GCT being a multigravida, and our thing is routine protocol is we do a GCT. Okay. Then why urine routine and culture sensitivity? Why do you want to focus on culture sensitivity?
Because asymptomatic bacteriuria is one of the reasons for anemia, ma'am.
Yes. asymptomatic bacteria has to be ruled out and it has to be treated. So unless you treat the urinary infection, hypothyroidism, correct it, then whatever the supplementation you are going to pump, the patient is not going to improve. And of course, this patient clinically suspicious of multiple fetal parts and QPFS, you need to have a detailed ultrasonogram. Okay, so now her findings. Laboratory findings are hemoglobin 7.2, PCV reduced, MCH reduced, MCHC reduced, and MCV. And serum ferritin is 10 micrograms. That's all. Okay, but whereas the normal is, we expect at least 30 to 150 micrograms will be the normal. And serum B12 is 112. And serum folate is only 2 nanograms. So this picture tells you this is a peripheral blood smear. So this will tell you what are all the findings in this peripheral blood smear.
Microcytic hypochromic.
Yes, hypochromic, microcytic, and you see only the microcytic RBC or sometimes macrocytic also.
Dimorphic
anemia. It is a case of dimorphic anemia, and you can see the hypersegmented uterus. Okay, so this is a case of dimorphic anemia. So what will you do in a low resource setup? What will be the ideal things? I think we have discussed this. See, complete hemoglobin
Complete blood count with indices along with peripheral smear will be beneficial to find out the cause of anemia exactly, ma'am.
Yes. So, how many of you have done a peripheral smear by yourself and have you read it? See, previously when we were all students, we are supposed to do complete hemogram and peripheral smear inside the lab that is present at the end of the ward itself. So we ourselves will do the peripheral smear. So, but now what are we doing? We are sending it only to the central lab. So this will help us to pick up earlier. Okay. So now the diagnosis you have told that it is a dimorphic anemia with multiple pregnancy and early decompensation. So how are you going to manage the patient?
This patient, since she's decompensated, she might require a blood transfusion.
She might require a blood transfusion. Okay, agreed. Especially multiple pregnancy, where the chances of preterm labor is going to be high. It's all the more we can go in for a blood transfusion. Otherwise, suppose if it is going to be a singleton pregnancy and if you have 6 weeks of time, what are you going to do?
Ma'am, if she is not decompensated and the HB is 7.2, singleton at 30 weeks, I would consider a IV iron infusion to treat this patient.
Yes. So IV iron can be given. Which one will you prefer? Iron sucrose or FCM?
FCM is preferred.
FCM is preferred. But if you are going to give FCM, what are the precautions you will take? Because now there is a lot of confusion regarding the role of FCM during antenatal period. No, we see a lot of allergic reactions. So where
FCM should ideally be given in an ICU setup, preferably. And the doctor should remain with the patient till the infusion ends. And ideally, an infusion should be started at a lower rate. There is no specific test dose for FCM. Initially, we'll give it like 8 drops per minute for first 5 minutes. Then we'll increase the dosage to about 70 to 80 drops per minute. And infusion should ideally be finished within 20 to 30 minutes. And patients should ideally stay for a monitoring of around some 1 to 2 hours post infusion to rule out late reactions, ma'am.
Which bottle will you use and what will be the diluent here?
Ma'am, we'll use 100 ml normal saline and preferably 500 mg of ferrium can be given 14 days apart, or 1 gram of ferrium can be given in 500 ml of NS, ma'am. And while giving ferrium, we'll stop iron supplement.
Don't call it, tell it as ferrium. You say it's ferric carboxy maltase should be given in 100 ml. 500 milligram can be given in 100 ml. What is the bottle you should use? It should be a glass bottle. Don't put it in the plastic container which has got 100 ml. Okay. Use a glass container. Okay. Can we add up any other drug with iron, this iron infusion?
No, ma'am, we should not.
We should not add up. No iron. But what are the precautions you will take? She said that she will give it in the ICU setup. Probably what are the things you will monitor prior to giving FCM and after giving FCM?
Pulse rate, saturation will monitor, ma'am.
Yes, pulse rate, saturation, and the blood pressure.
BP.
And post infusion also we need to monitor. What are the side effects you can get because of FCM?
Ma'am, it could rain. It could rain. It
could have
could
given
range
lot of FCM infusion, no, in your practice. So what is the common problem that you face? The patient
complain of headache and breathlessness, ma'am.
Yes, tightness of chest.
Yes, ma'am.
Okay. Then?
Sometimes urticaria, chills.
Urticaria. Then? Most common?
Headache, ma'am.
Headache. Then? Pedal edema. Have you noticed pedal edema? Pedal edema, I have seen patients coming back after 2 hours saying that she has edema. She will go to the bus stand and then she will come back. So pedal edema is one important problem. So like breathlessness and sudden, so these things. And rarely you can have serious adverse effects secondary to FCM injection. So now what is the current current take-up by the NHM? Are they advising FCM? சொல்லுங்க.
NHM allows FCM infusion.
Yes, FCM infusion. But in which trimester? Only in second and third trimester. Not give it in the first trimester.
First trimester.
You think the other places in the periphery, in the primary health center, what is the iron, injectable iron they are giving?
Iron sucrose.
Iron sucrose. Iron sucrose is time tested and we have a lot of experience also. So probably there is some group or some evidences which says that FCM preferably should be given for non-pregnant, but still we have documentation to say that the FCM can be very safely given during pregnancy. So now then how do you calculate the iron requirement? This particular patient has got an iron weight of 60 kg and she has a hemoglobin of 7 grams percentage. So what will be how will you calculate the total iron dose the patient needs?
We can calculate using Ganzoni's formula, ma'am, which is the required iron dose would be 2.4 into target hemoglobin, which is around 11, minus actual hemoglobin into pre-pregnancy weight plus 500 milligram for the replenishment.
500 milligram for replenishment of the stores. So that has to be calculated. Probably it is very high. We can split it into 500 milligrams and give it at 10 days or 15 days apart. So then what will be the immediate, how will you find the immediate improvement? What the patient will say?
The sense of well-being.
Symptomatic better improvement.
Yes, the patient will be symptomatically better. Okay. So then coming to IV iron sucrose, you have said all the principles are the same. 10 to 20 minutes, it has to be given in 100 milligram should be given in 100 ml. And sometimes we give even 200 milligram in 100 ml normal saline. And there should be a minimum gap of 2 to 4 days. Here also you calculate the total days and then you split it and weekly twice or 3 times in 1 days you can give it. So then will you give oral iron along with IV iron?
No, ma'am.
Should not be given.
It should not be given. At least you withhold oral iron for a period of 10 to 15 days. Then when should you expect the iron level to increase?
After 3 weeks.
After
3 to 3 weeks. And what will be the first evidence to say that the patient is improving? If you get the reticulocyte count will be the first evidence to say that she is responding. So along with that, what are the other things you will supplement? I think this she has given already in details. I will skip this. So now, what are the other drugs you will give along with IV iron?
Vitamin C,
yes.
B12 and folic acid, ma'am, in this
folic acid and protein is a must. Protein is a must. You should give the patient vitamin C, B12 by needle and then folic acid. Okay. So now suppose, what are the contraindications for iron therapy? Not all patients with iron deficiency can be, anemia can be given IV iron, isn't it?
If the patient is having hypersensitivity, previous allergic reaction to iron
Don't
will
give.
not
Yes.
therapy. And
Common
normally,
in first trimester, we should avoid iron.
Okay.
and if she is a thalassemia patient, due to fear of iron overload, will skip
Yes.
iron therapy.
Iron overload in any of these hemoglobinopathies is better to avoid.
The patient is having any fever, AG.
And for liver failure and renal disorders, will withhold iron therapy.
Yeah, we will not give liver damage and acute renal failure. We don't give. Then active rheumatoid arthritis also we don't give, because if you give iron therapy, the patient will complain of sometimes joint pains, body pain. Have you seen?
How many பேசுறது கேட்கவே மாட்டேன்.
என்ன மேடம் கேக்கலையா? ஹலோ,
நீங்க ப்ரோசீட் பண்ணுங்க. அவங்க வேற ஏதோ பேசுறாங்க. ரமணி மேடம், யூ ப்ரோசீட்.
ஓகே. சம்பத், இதுல இடையில ஏதாவது சொல்லணும்னா நீங்க சொல்லுங்க. ஓகே.
கண்டிப்பா மேடம்.
Okay, what are the indications for blood transfusion? This particular patient is around 30 to 32 weeks. Now, is there an indication for blood transfusion in this particular patient?
Yes, ma'am. If it is a decompensated anemia, then that is an indication for blood transfusion. Usually, we split it into less than 34 weeks and greater than 34 weeks. If at all she is greater than 34 weeks, if HB is less than 7 itself, we usually give blood transfusion for the fear of risk of preterm labor. Or if at all she is decompensated, at any cost, we give blood transfusion, ma'am.
Yes, we have to give blood transfusion. So, severe anemia with decompensation, these are all the indications. Okay, then the other indications for blood transfusion, when the patient has got APH or PPH, or when there is an acute hemorrhage, when the hemoglobin level is definitely, I will take it as 7. And if the patient becomes hemodynamically unstable also, we are going to give blood. Then
when she shows signs of decompensation.
Yes, whenever there is any signs of hemodynamic instability, then we need to give blood transfusion. So in the postpartum period, what are the indications for blood transfusion?
When the hemoglobin is less than 7 grams,
we need to give blood transfusion. What are the complications of postpartum anemia?
Subinvolution of uterus, ma'am, lactational failure, infections, sepsis.
Then what happened to the embolism?
Thromboembolism.
Thromboembolism is also high in
postpartum depression.
Postpartum depression, all those things we need to consider. So, how will you treat postpartum anemia? You give blood transfusion. Suppose if the hemoglobin level is less than 7, we are giving blood transfusion. But if the hemoglobin is found to be 8, what will you prefer to improve the anemia in postpartum period?
IV iron would.
We are giving IV iron. Safely FCM or sucrose can be given. So, if you are going to plan giving ferric carboxymaltose, what will be the dose you will prefer?
1 gram.
See, even 500 milligram for the initial time being is enough. Okay, 500, because there was one study done at by our own colleagues where they have 2 groups, the same anemia hemoglobin percentage. They have given one group of patients 500 milligrams, and one group they have given 1 gram. They found out ultimately at the end of 4 weeks, the results were the same. So at least minimum of 500 milligram of IV iron should be given. Okay, how will you follow this patient? See, on follow-up of this patient, multiple pregnancy, she went into labor at 34 weeks. First baby was a breech. So the decision to deliver by C-section was taken. During C-section, she started having atonic PPH. How will you manage, and what are the other management options? See, first of all, multigravida, 34 weeks, twin conception, first baby presenting as breech. Would you want to do a C-section or would you want to do a vaginal delivery?
preterm with first breech, go for cesarean, ma'am.
You want to go for a C-section. And another thing is, in a multiple pregnancy with already pre-existing anemia, we expect atonic PPH, which can be handled effectively during LSCS rather than vaginal delivery, isn't it?
Yes, ma'am.
Yes. So C-section was done and she started having atonic PPH. Now, how we are going to manage? See, in anemic patients, we anticipate atonic PPH. So now you have to go ahead with prophylactic drugs to prevent PPH. So now tell me, what are the prophylactic drugs you will give her to prevent postpartum hemorrhage?
Oxytocin.
Oxytocin.
20 units can be 40 international units should be given, ma'am. And carbitocin we can use, ma'am.
First one, you will prefer carbitocin or oxytocin?
Oxytocin, ma'am.
Oxytocin. Okay. But carbitocin, maybe it depends. We can give carbitocin IV and put in the IV line 20 or 40 units of oxytocin. Then what else?
Carboprost.
Carboprost. Then
Misoprostol.
Misoprost. Then
Tranexamic acid.
Tranexamic acid. So this bundle, this PPH bundle should be initiated immediately. Give her oxytocin because your first line is going to be only the oxytocin. Once if it is not getting control, then we are giving carbitocin, prostaglandin, misoprost, then tranexamic acid. Don't forget, because tranexamic acid definitely reduces the mortality and reduces the bleeding. Within how many hours you should give tranexamic acid?
3 hours.
Within 3 hours. We don't wait even for the 3 hours, because it not only corrects the traumatic PPH, but also in atonic PPH, it definitely helps. So then what will be the dose that should be given?
1 gram.
1 gram.
1 gram stat, followed by how many hours it should be repeated?
8 hours.
8 hours you repeat it, so that for at least for 24 hours you maintain it. Or in other words, what are you going to do?
Active management of that stage.
Active management of this Amstel we are following. What about the patient is undergone C-section? During the abdomen is open. What, apart from the drugs, what are the other things? How will you manage control PPH?
Stepwise devascularization and compression sutures.
Stepwise devascularization. Before that, beeling suture. Initially, it is very useful. Any sort of compression sutures along with that stepwise devascularization. Then is internal iliac artery ligation indicated in this patient? Probably not. It reduces 80%. Yeah, it may not be needed in in majority of the patients. Then otherwise, what can you do?
We should arrange for
simple method.
Tamponade.
Tamponade. What tamponade?
SR cannula we can use.
Yes. Panicas carna is very, very comfortable, and you can put it inside through the cervix from the abdominal route. You can put it and connect it. So that also becomes a very, very useful tool to prevent the active bleeding. So this, then what about the blood? She is already anemic. So when you are posting this patient for C-section also, we should be ready with cross match, at least 2 units of what blood? PRBC. Then anything else? FFP, cryo, we have to be ready. Okay. So how will you give, suppose in cases of patients with a massive transfusion protocols, how will you schedule the drugs, schedule the blood products?
It is 1:1:1 ratio of 1 PRBC to 1 FFP and 1 platelet.
Okay. So then also we can give, if you are going to go for massive one, you need to give the patient calcium supplementation also. So now coming to the second case, I think you have all handled the first case very beautifully. Now let us move on to the second case. Mrs. V, 32-year-old. Sampath, any comment on the first case? Sampath?
Madam, no comments, madam. Let them decide also of the menses index.
Okay, menses. Okay. I think that comes in the CBC itself. Okay.
வருதா மேடம்?
சொல்லலையா அதுல previously?
இல்ல அந்த தலசீமியா வந்து ரூல் அவுட் பண்றதுக்கு the simple test அது ஒண்ணு
Yeah,
மட்டும்.
simple test that we routinely do it in our hospital. CBC means it will include the menses in the index. Okay, so let us move on to the second case. Mrs. V, 32-year-old, G5P4, live 2, abortion 2 with history of 9 months of amenorrhea, was admitted in the hospital with severe pain and pallor. She had only 3 antenatal visits in a PHC on irregular follow-up. Is it feasible in the current days?
No, ma'am.
No, we are giving the PICME number, and if the PICME portal, if the entry is not done on the particular antenatal visit day, immediately the VHN will go and pull her out. So this patient was immunized, not taken folic acid, iron or calcium supplementation properly. Okay, so then on examination, she was very pale, facial puffiness, sallow in color, dyspneic, pulse rate of 130, respiratory rate of 26, BP 140/100, and pedal edema, and JVP was elevated. Per abdomen, abdominal wall edema was ++, uterus term, tender, tense, and irritable. FH irregular, and 3/5 of the head was felt above the brim. Per vaginal examination, vulval edema was there, and cervix is dilated to 6 to 7 centimeters, loosely hanging. So now what is your membranes are absolute, caput ++ at the brim. What is the diagnosis?
Severe anemia,
severe
complicated pregnancy with signs of obstructed labor.
Yeah, signs of obstructed labor, severe anemia, and impending.
Preeclampsia.
She has preeclampsia. Then not only that,
Impending rupture.
So we need to think about impending rupture. So the diagnosis is severe anemia and obstructed labor, impending rupture uterus, gestational hypertension complicating pregnancy. So all these things you have mentioned. Now the question is whether this patient, what will you do immediately? You need to get admitted in the ICU or the HTU. Then what else you will do?
We should check your
What should be done immediately?
Oxygenation, ma'am, and we have to catheterize the bladder before shifting to the ICU. And 2 white bore needles, man. Blood for cross matching should be kept ready. And let's see her vitals immediately. And take all investigations like CBC, serology.
Correct her dehydration and shift the patient
to a
to
multipara monitor, measure everything, blood sample to be taken, and a senior person consultant should be involved in managing this particular patient. Okay, then CBC, urea, creatinine, electrolytes, CTBT, sugar, ABG, everything was done. Preferably, because of her tachycardia, tachypnea, if needed, ABG can also be done. And what is the role for bedside echo and ECG? Is there a role? Because you are telling she is a case of gestational hypertension also.
Rule of peripartum cardiomyopathy, ma'am.
Not only peripartum cardiomyopathy, but nowadays our government is insisting upon antenatal echocardiography, and that too in the first trimester. Somehow she missed everything. So what will you expect in hypertension patients with echocardiography?
Ventricular hypertrophy, if she is the chronic.
LVH should be watched for, and if there is LVH, she is a case of which hypertension?
Chronic
hypertension. And there may be, when there is superadded preeclampsia, maybe you can, similar to ascites, we can have pericardial effusion also. Okay, so you need, this patient is being, get ready all the blood samples, blood and blood products, and plan for massive transfusion protocol, because already we think that it is a case of impending rupture. Okay, correct dehydration, flush her with it. Sometimes if you drain the catheter may show high colored urine, or even blood stained urine can be there. So get the OT, obstetrician. So you are immediately going to plan for surgery, or you are going to wait?
Plan for surgery.
Plan immediately for surgery, and there you should involve the senior obstetrician, anesthesiologist, pediatrician, and intensivist also should be ready. So then more than that, you need the informed consent. So just don't take her, you have to get the informed consent regarding the surgery and what you are going to do. Unless you open up, we cannot say Maybe the patient can even have a broad ligament hematoma, and she might have a atonic PPH, and she might need a hysterectomy, obstetric hysterectomy. So regarding the maternal and the fetal status, we need to explain. Then blood and blood transfusion products, are we getting a separate consent or not?
Yes, ma'am. We are
getting a separate consent. So probably, if feasible, videograph the dialogue of the consultant and the attender and get detailed consent of this procedure. That is very important. Then what are the special things we need to tell these attenders regarding the surgical complications?
Ma'am, risk of hysterectomy might be there, ma'am, because she is already anemic and there are more chances of atonicity. And already she is in obstructed liver, so there are more chances of bowel bladder injury, ma'am.
Bladder injury. Okay. Then
need for ICU stay and elective post-op ventilation and
Yes.
complications of blood transfusion.
Yes. Patient can go in for pulmonary embolism. Patient can go in
Disseminated
for
intravascular
on-time
coagulation.
arrest. So all
Cardiac
those
arrest.
we need to cardiac arrest. So all these things. And what about the baby? The baby fetal heart is feebly heard. So there is a chance for baby being severely asphyxiated or an IUD baby, and the baby might need NICU care. And again, we need to tell them the risk of hypoxic problems that can be faced in the baby. Okay, so proper documentation should be done. Okay, what are the problems we can get? So this you have already mentioned: hysterectomy, bladder and ureteric injury, prolonged catheterization. So in this patient, even though if there is no bladder injury, how long you will retain the bladder catheterization?
For 2 weeks.
At least for a period of 1 week. Okay, not in 2 weeks we retain only when we have the bladder injury, but always in patients with bladder compression, at least minimum period of 1 week. Then DIC can also happen because of severe anemia, hypoxic ischemic encephalopathy, risk of cardiac arrest, blood transfusion complication, elective ventilation. My panelists are expert. They have included all the complication. And lastly, the maternal mortality and morbidity has to be explained, and neonatal complication. We have done with that. So now the blood hemoglobin report is hemoglobin is 3.2, PCV 12, platelets 1.2, urea is 40, sugar is 124, creat 1.8. That is diagnostic of dehydration. Electrolytes are normal, potassium and sodium. HCO2, that is bicarb is low, chloride is normal. Viral markers negative. So blood and blood products are arranged. Drainage of the bladder showed blood stain urine. All these things we have here. So now the next thing is patient was shifted to the OT. What anesthesia you will prefer?
General anesthesia.
Yes, never go for spinal because spinal shock can also aggravate. So general anesthesia is preferable and hemodynamic stability can be achieved. And as you said, post-operative elective ventilation is feasible when the patient is on general anesthesia. And we can have a better oxygen supplementation. And again, BP can be maintained and avoided spinal hypotension. Then continue elective ventilation and blood products. How long you should continue blood transfusion and blood products transfusion? Minimum of hemoglobin of
8 grams.
8 grams. That should be the cutoff beyond which you can extubate the patient. Okay. So most important is avoid sepsis. What antibiotics you will give?
Third degree cephalosporins.
Third degree. Third thing, cephalosporins, preferably cefpoaprosone sulbactam, and then metrogel, amic acid,
and anaerobic cover.
Then temperature should be watched periodically, and sometimes if you feel the patient has got patient is hypothermic, is it a good sign or a bad sign?
Bad sign.
Yes, hypothermia in a patient with a shock is very, very. Madam, யாரோ பேசிட்டே இருக்கீங்க. Please put off your mics. Please switch off your this one, audio.
Dr. Sarada.
Okay, she has now put off. Then pediatric team should be kept ready for resuscitation. So now the intraoperative findings. You will go for a midline incision or a RPM incision or a Fenton steel. What incision?
Fenton steel, ma'am.
You want to go for a financial incision in emergency, threatened rupture, suspecting hematoma?
But
Sampath madam, சொல்லுங்க, what incision?
மேடம் இப்ப எல்லாம் வந்து எல்லாமே பினான்சியல்லே போய்க்கிறாங்க.
Okay.
சென்ட்ரல் வேணும்னு இல்ல.
Financial with muscle cutting may be useful.
மசில் கட்டிங்.
Muscle cutting because that can
RPM, LPM, midlineலாம் இப்ப ரொம்ப யூஸ்
போடுறது இல்ல. Okay. Then you will go for a classical C-section or a LSES. It depends. If the patient has got already an established bandle sling, how will you go? Classical incision because you need to cut through the bandle sling. So the findings were pale, lower segment was stretched, impending rupture. Okay. So then baby delivered through the lower segment incision. If you are going to do it by lower segment cesarean section, where should you put the incision in LSES in a patient with obstructed labor?
Higher level, because the bladder will be drawn up at a higher level of the utrovesical peritoneum.
Yes, don't separate the utrovesical peritoneum. Even if you separate it, put the incision at the higher level. What will be the what will be the problem if you are putting it at a lower level?
Thinned out lower segment.
Yes. So that will
bladder injury.
Bladder injury. Then two more important things.
Extension of the angle into the uterine vessels in the lower segment.
Lower segment can give the Röntgen extent vertically to the lower uterine segment. Then one more thing.
Laterally through the
Pardon?
or laterally through the broad ligament. Hematoma can form in the broad ligament.
Yes. Then most important thing is
difficult in delivering the
vagina
head.
will be in the same plane. The incision what you are putting it may be in the vagina. Okay, so that we have to be, that is the reason why we say we put it in the highermost position. So severely asphyxiated baby weighing 3 kg with big caput was delivered, followed by placental delivery. The incision extended to the left side and uterus was exteriorized. Normally, we don't exteriorize the uterus, no, during closure of the uterus in LSES. But in these patients, it is always better to exteriorize the uterus and see whether it has extended on either side, whether the uterine arteries are involved, and always don't fail to have a look at the posterior surface of the uterus. Okay. Severe atonicity was there, and there was a broad ligament hematoma of around 10 to 12 centimeters seen, which was bleeding torrentially. So now how we are going to modify your procedure?
Better to proceed with hysterectomy.
Cesarean hysterectomy, or will you go for conservation of uterus after evacuation of the hematoma?
She is already a decompensated patient, so better to proceed with cesarean hysterectomy.
So earlier cesarean hysterectomy will be advised, but in such cases, in such a huge broad ligament hematoma, what are the surgical complications you can face?
Injury to the ureter.
Injury to the ureter is very important, and beyond that, sometimes there will be recession of the vessels retroperitoneally.
Leading to retroperitoneal hematoma.
Retroperitoneal hematoma can be very massive. So these are all the problems. Okay. Then that is severe blood loss, bladder and ureteric injury you have already mentioned, and extension to the vagina and the colporexis. I told you, no, the lower segment can go vertical tear and it can enter into the vagina and the colporexis, and need for bilateral internal iliac artery ligation in order to reduce the blood flow. And hence you need a team of obstetrician, surgeons, and the urologists. So that is why you have alerted already the pediatrician and the surgeon, obstetrician, and the transfusion medicine consultants. Okay. So what are the post-operatively? The patient had a total hysterectomy with careful ureteric identification and mobilization combined with internal ligation. A drain was kept close. CBD to be maintained for a minimum period of 2 weeks. So how to go about with the blood transfusion? So here you are going to follow up which protocol?
Massive transfusion protocol.
Massive transfusion protocol. And the intraoperative blood loss is 1.5 to 2 liters. Sometimes it may be even beyond 3 liters also. We have to calculate the blood volume to be placed prior to surgery and intraoperative loss. So 1 unit of packed cells will elevate by 0.5 to 0.75 grams only. So that we have to calculate that and then give her 1:1 ratio that massive protein transfusion protocol should be planned. So this is what we have already discussed. And then calcium gluconate also we have discussed. Elective ventilation you have discussed. Monitor fluid management is very, very important. You cannot load the patient and hence the central venous pressure monitoring will help us to monitor the fluid management. And antibiotics, of course, we have discussed earlier. Third generation cephalosporin, amikacil and metrogyl. And definitely thromboprophylaxis is needed or not?
Yes, ma'am.
Yes, after stabilization of the patient. Before stabilization, there is no need. By maximum, by 8 to 12 hours, the patient would have been stabilized and then we can start on thromboprophylaxis. So what are the problems we anticipate during intraoperative period? What are the problems we face?
Patient can go into shock, ma'am.
Yes. Cardiac arrest.
Cardiac arrest.
So we should be ready with defibrillator and bedside echocardiography. All drugs which are needed to resuscitate the patient, inotropic support, and the role of intensivist is very, very important. Okay, acute management of cardiac failure has to be done and correction of hypotension with appropriate IV fluids and blood and blood products. And hypothermia is one thing which should be prevented. Okay, because hypothermia is going to tilt the balance and hypocalcemia should be avoided. So the causes for cardiac arrest in these situations are hypoxia, hypovolemia, hypothermia, hypo or hypercalcemia, and acidosis. So always in massive transfusion protocols, apart from calcium, we need to supplement them with soda bicarb should be given.
Correct acidosis.
Of course, hypoglycemia should be corrected and watch for arrhythmias. Okay, so the patient arrested on table as soon as the baby was delivered, revived with cardioversion and inotropic supports given. BP was 60 query, pulse rate was 150. Now how to proceed? This is what we have. The patient deteriorated in spite of resuscitation and patient can have a slow recovery with residual morbidity. Okay. So complications expected, I think we have already discussed. So post-operatively, all these patients, after correcting also, basal collapse of the lung is very important. And in the post-operative period, if the patient has got fever, what are the reasons for fever in a patient like this?
Sepsis to be ruled out.
One is sepsis. Okay. Second one is
aspiration pneumonia should be.
Yes, that is main thing. Basal collapse due to aspiration pneumonitis, blood itself, malarial infection, all those things can give fever. Okay, so this has to be monitored. And then congestive heart failure can happen, DIC, ARDS, and these are all some of the early intraoperative complications are. What are the intraoperative surgical complications? We have discussed about the bladder ureteric injury, bleeding, sepsis. Wound infection is also very common. Why wound infection in these patients?
Anemia causes poor healing, ma'am.
Yes. Again, MRO, we do not know how long sepsis causes and prolonged surgery can cause. Okay. So these are the things we should anticipate. And delayed complications are morbidity, post-operative morbidity, depression, lactation failure, and even we can get vesicovaginal fistula and incisional hernias. That is what is meant by massive transfusion protocol. What do you mean by massive transfusion protocol?
It is a protocol to facilitate the blood issue of blood products. It is a communication between the caregivers and the blood bank to ease the issue of blood products. When we expect more than 10 units to be transfused to the patient, especially during a postpartum hemorrhage or a trauma, this massive transfusion protocol should be activated.
Yes. So at least, or when you expect the transfusion rate is beyond 150 ml per minute, then 50% of the whole volume of the body is transfused, then we call it a massive transfusion protocol. What are the complications?
Dilutional coagulopathy, hypothermia, hypocalcemia, acidosis.
Magnesemia, citrate toxicity, metabolic acidosis, hyperkalemia, transfusion-induced trolley, acute lung injury. Okay. So how can you avoid this? How can you avoid all these complications? By giving regular antenatal checkup, correction of anemia, oral or IV iron, blood transfusion in the antenatal period, and at least maintain pre-delivery hemoglobin of minimum of 10 grams. Okay. So, an assessment of CPD should be done earlier so that the patient gets admitted electively in a hospital for delivery. And antenatal counseling for the entire family. Nowadays, that too, with the history of home delivery by the husband, we need to counsel them extensively. And delivery in high-risk cases in a tertiary care center. So, I think I'm coming to the last thing. This is all the postgraduates should know about the TEG, thromboelastography. So, this what when it is done, thromboelastography?
The setting up of DIC.
Yes. So this will tell you what are the from based on this thromboelastography, what are all the informations you get from this? The shapes of this thromboelastography will tell you what is the problem. For example, it is like this in normal. When the patient has got anticoagulants and hemoglobinopathies, this I think you have got various phases. I'm not very sound in this thromboelastography. Probably I just wanted to put it just for the PGs and the other people to understand there is an important role of thromboelastography in severe postpartum hemorrhage or any sort of hemorrhage. Okay. So follow-up is the patient was transfused with 18 units of blood, electively ventilated, CBD maintained, inotropic support and antibiotics given, fluid adjusted, extubated at 72 hours and with a hemoglobin of 8 grams, thromboprophylaxis given, and mother and baby went home very well. Thank you. So these two are my own patients with whom we have managed it appropriately, having a positive maternal outcome, maternal-fetal outcome. So now let me thank all my panelists for their very good input. Thank you so much. And I should thank TNFOG and especially Dr. Sampath and the President Amla Devi Madam and Shanti Rani who has been coordinating with me. Thank you so much.
Thank you, madam. Wonderful panel.
Thank you.
Thank you, madam. Super panel.
Okay, thank you.
As usual.
Medical college la padicha madiri irundhathu.
Okay, thank you so much.
We were remembering the olden days.
Okay.
Madam, always a good teacher. Yes.
Thank you, Meena. Okay.
Thank you. Shall we go with vote of thanks, Radhika Arkala? Radhika illana Shanti madam sollirringa vote of thanks?
Definitely, madam. Okay. 1 minute.
அமலா மேடம் அடுத்த மாசம் யாராவது ஒரு சொசைட்டிய பண்ண சொல்லிடுங்க மேடம். மாசம் ஒருத்தருக்கு கொடுத்துடலாம்.
இந்த மாரத்தான்.
ஆமா மேடம் பண்ணட்டும். லெட் தம் டு. நான் இத போதனா நான் பண்ணிக்கிறேன். இத வந்து மாசம் ஒருத்தர் பண்ணிட்டோம். லெட் தம் கெட் இன்வால்வ்.
கேட்றோம்.
சரியா? நம்ம குரூப்ல போட்டுடலாம்.
டேட் தானே?
செகண்ட் ஃப்ரைடே.
செகண்ட்
ஃப்ரைடே 2 யுவா செலக்ட் பண்ணனும் ஒரு பேனல் அவ்வளவுதான். சரி.
On behalf of TNFOG for today's program, I thank President Amala Devi Madam, Secretary Sampath Kumari Madam for their constant effort to put this program going on in spite of all hurdles. And thank you, Sampath Madam, for pulling on with this marathon. And I thank our chief guest today, Dr. Sarada Jain and Dr. Nagaraj for their august presence today. And I thank Madhubala Madam to accompany me to judge the 2 young speakers, Dr. Surya and Dr. Monisha, who have done extremely well. And my sincere thanks to Ramani Devi Madam, whom we all look upon as a guide, as a mentor. Thank you, Madam, for moderating this extremely essential, crucial panel. And I thank all the panelists, Rasa Bharati, Vijitra, and Sweta, Kanmani, Preeta, and Vidya Lakshmi from Dindukal, Teni, and Karur for participating this panel and sharing their valuable opinion. And I thank Radhika Gauri for the MOC for the entire this series of marathon. Thank you everyone, and thank you for the delegates who have joined today. I hope you should inform all others how beneficial this is going to be, especially for the postgraduate students, and encourage them to participate. Thank you one and all. Thank you, madam.
Thank you, Dr. Shanti Rani. Thank you. We'll close. Thank you, Sahiti.
Thank you.
Thank you, Ramani madam.
Thank you. Bye.
Sahiti. For the Sakti Shield entire team. Thank you.
Thank you.
Thank you, madam.
Thank you, madam. Thank you. We'll close. Good night.
சாயங்காலம் தான் ஆயிருப்பா, இப்பவே குட் நைட் சொல்றேன்.
மேடம் நம்ம தான் இருக்கு, நாளைக்கு பாப்போம்.
நாளைக்கு பாப்போம் கண்டிப்பா. ஓகே அமலா மேடம், தேங்க்யூ.
சாகிதி முடிச்சிட்டாங்க போல.
முடிச்சிட்டாங்கடா ராதிகா.
ஆமா போல.
நல்லா இருக்கு. நல்லா இருக்கு.
நானும் ஒரு எமர்ஜென்சிக்கு போயிட்டேன்.
ஓகே ஓகே. நீங்க சாந்தி மேடம் முடிச்சிட்டாங்க.
ஓகே ஓகே. தேங்க் யூ.
ஓகேடா, பை.
நீங்க எப்படி இருக்கீங்க? பை.
நல்லா இருக்கேன்.
தேங்க் யூ. சாகிதி
பைடா. பை.
பை.